right, so I've been tasked with speaking about precursor lesions and speaking about curability, not a word we get to use very often in myeloma, but hopefully someday soon. I'll go a little bit through risk stratification and how to think about the smoldering patient and the precursor setting, a little bit on the evidence we have to date. As you know, it's not very extensive. Some mention on ongoing trials, and hopefully get you thinking about future directions and make this a much more interesting talk in the next year or so. All right, so a word on background just to reorient you and get you thinking about where we are. I think in general, once you have end organ damage in your active myeloma, we're all very comfortable treating. In the MGUS setting, very low burden of disease, very low proteins, we're very comfortable not treating. But between these two extremes, there's a very large and heterogeneous population that we clump together and identify as smoldering myeloma. So they have a little bit more plasmacytosis, they have a little bit more of a tumor burden, but so far, no end organ damage. And that's a very different population. So mostly, the rest of the talk will be focused on them. As far as epidemiology, also not something that's easy to look at. The SEER database that we rely so nicely on for myeloma and other cancers doesn't really capture smoldering. We do have two nice large data sets, one out of Sweden and one out of the US, and luckily the data does seem to coincide and support each other. As of 2016, we had about 4,000 cases diagnosed in a year, but I'm fairly sure that's a gross underrepresentation. Again, I don't think we're capturing all of these cases. And although the prevalence does seem to change, again, between the Swedish and US groups and different socioeconomic breakdowns, the survival and the effect on outcomes doesn't seem to be statistically significant. So since this was the original, I think, landmark paper that explains to us that while you're at an MGUS state, you have a very nice steady rise of 1% per year, the risk in the smoldering group, again, is very variable, particularly with that early rise. And I think this speaks to, again, the heterogeneous nature of this disease. About 50% of patients will progress within those first 5 years, and for those who haven't progressed within 10 years of having the same diagnosis, their risk is now parallel to the MGUS. So these two patients who may be seen in the same clinic at the same day and get the same diagnosis of smoldering myeloma will have very different outcomes and should really not be treated the same. I think it is exciting. I've been using the slide for many years and it's certainly getting dated, but the concept is still there. We are learning so much, especially in the basic sciences, identifying the different players, the different roles, the changes that come into play, but we don't yet have a recipe for making myeloma. When that B cell commits to MGUS rather than being a productive member of your immune system, it's one step. And again, many of them will just go as far as MGUS and there they'll stay. What happens later, we have a lot of correlation. So this independence of the microenvironment and the role that all the different players play are, we keep being very proud of findings, but we're not at a place where we can explain it. The IL-6 and other cytokines involved, certainly angiogenesis and bone destruction. We've also identified cytogenetic changes that are early versus late, but there is no guarantee and there is no, once this step happens, that is the definition of active disease. So as of now, smoldering myeloma, by definition, you must have an M protein and a plasmacytosis, which we now have an upper limit on, and no end organ damage. So specifically, this is this CRAB criteria we've long known and loved, but given the recent update, also includes what used to be known as the ultra high risk smoldering. So patients who have over 60% marrow involvement, an excess of light chains or more than one focal lesion on MRI are now excluded. They are considered myeloma-defining events and will no longer be included in the rest of our conversation. So I will take some time to speak to risk stratification. I think both in active myeloma and in smoldering, our understanding of, as Dr. McHale just pointed out, the multiple myelomas is an area that really, I think we still have a lot of room to grow in identifying the different subsets that require specific therapies that will do particularly well or not, and treat them differently. So the Mayo Clinic did give us the earliest model. Most patients, you will have the information on plasmacytosis, M protein, and free light chain ratio. And these do stay separated through time. So these are three very different groups. And if you look at the 5-year progression risk, again, all comers on average about 50%, and that's our medium risk group. The low risk is about 25, so about half, and the high risk 3/4, so a very nice separation. And the Pathema group, I would argue, is the second most used, most commonly, the one we've gotten to know the best, and this one relies on immunopoiesis and the abnormal phenotype of the plasma cells. But even when these two are compared, the discordance rate is very high. So you may be labeled as low risk on one model and high on the other, or vice versa. So I think there's a lot of room to grow. And if 2 wasn't enough, we now have a growing list of very good, very nice curves that separate out depending on what you look at. So I think the SWOG is important because it brought GP. It's the first one to use GP. In Heidelberg, they're using specific translocations and cytogenetics. There's some incorporation, especially in the Barcelona, of an evolving phenotype. So different things that are evaluated. So instead of identifying them individually, I think en masse, these are things that are worth looking at and that will separate out the so-called high-risk smolderers, because nobody is really eager to treat all smoldering myeloma. It's identifying the high risk, which by definition have a 50% chance of progressing within 2 years. So most of the models that I showed in the last slide have some combination of a tumor burden measure, be it by plasmacytosis or by M-spike or by light chain burden. Many times looking at the phenotype, again, the specific aberrant plasma cells or reciprocal depression, the immunopoiesis seen with the uninvolved chains. A few of them use cytogenetics, specifically the 414, deletion 17, and 1q that we're used to, but also hyperdiploidy is now a high-risk feature, and if available, GEP. A word on the evolution, again, originally described by the Spanish group. The rate of change, there are some smolderers that will start to pick up speed, and that's a high risk. Recently, the Mayo sort of flushed that out, gave us some very concrete numbers on the rate of change over time, and also defined an evolution of anemia. So if your hemoglobin's changing at a certain rate, that too can identify a high risk group. And lastly, radiologic findings, again, whole body MRIs. There's a good bit of data, but not everybody's using them. PET CTs, not everyone has access to. So uniting the data that you have with the patient population and coming up with that unified risk stratification would be very useful. So in general, regardless of what model you use, if you fall under that low risk category, we assume you have approximately a 10% risk of progressing at 5 years. Those patients can probably get away with being monitored annually. The intermediate risk that run around 40% risk of progression at 5 years, you might want to see every 6 months. And then the high risk, again, by however method you identify them, these are patients that should really strongly be considered for clinical trials so that we can learn from them and use all of our experience to guide management moving forward. So far, again, this is not as long a section as I would like. Back when we used to treat myeloma with melphalan and prednisone, we started treating smolderers, and not surprisingly, there was really no effect on response, time to progression, or overall survival. We stopped doing that. Then I think ahead of our time, we started looking at the microenvironment and can we just use bisphosphonates and alter outcomes? Again, not shown any response or effect on the myeloma, but did at least show a benefit in reducing skeletal-related events. Here's a graph with zoledronic acid. This was also done with pomidronate. There were a number of studies that did seem to concur. And then with the advent of the first immunomodulators, and thalidomide was used single agent with the addition of dex, they were actually starting to get some responses, and sure enough, if you're able to respond, you have a longer time until requiring salvage therapy. But as we all know, thalidomide is not the easiest drug. It does come with a high toxicity course, and it's hard to tell someone who's asymptomatic, who may never need an intervention, that they need such a therapy. And I will mention the addition of bisphosphonates to thalidomide. There were several phase 2 studies, including then a phase 3 that randomized thalidomide, zoledronic acid with or without the thalidomide. And per their definition, they did seem to see a benefit. However, if you use the development of CRAB, there was no delay in that end organ damage. So again, not something particularly worth pursuing. I think everything started to change when this paper came out, which certainly caused a lot of debate and opened up, I think, a lot more of this era, using lenalidomide and dexamethasone, again, in high-risk myeloma. We were seeing responses. There was an induction phase and a maintenance, and as with active disease, continuous therapy does deepen and extend responses. And unlike with its predecessor, at a very low toxicity. So mostly grade 1 and 2s, very manageable, something that you could actually consider for an asymptomatic patient. But it did open up, as I mentioned, it received quite a bit of criticism. It wasn't perfect, but I don't think we have any studies that are. And it did sort of open up more questions about the safety and length of therapy, which is an ongoing issue, the effect that that might have on quality of life and the cost effectiveness. So are we just starting earlier and adding years to the therapy? Brings up the role of consolidation and maintenance, again, in what is considered an asymptomatic state. What role does age play into our assessment and our decision to start such a therapy? And what do we do at biochemical progression, and how do we monitor these patients? And again, going back to the concept of how do we risk stratify them, whether the techniques and the testing, for example, if GEP is how you define high risk, what do you do if you don't have that data on your patient? And I would say the newest and greatest, really now using a triplet therapy, which is one of our more powerful ways of treating active disease. And this study included both newly diagnosed and about a dozen smoldering patients. And I think in addition to showing the benefit and the power of using a triplet combination, the way the study was done and the concept of using MRD negativity as an endpoint, I think, was definitive and altered the way that we now move forward. And this is just adapted from one of their images. They had not only MRD data, but on those patients, comparing multiple ways of evaluating the depth of that response. So I think as our technologies get better and as we're better able to detect whatever is minimal residual disease really becomes minimal detectable. And is there a threshold beyond which we can start using words like cure? So who knows? When I started putting the slide set together, there were 51 open studies currently for smoldering myeloma, 44 of which are interventional. So to say we're not treating smoldering myeloma, I think is misguided. Most of them are really aimed to prevent that progression. Can we save people's kidneys and bones and the morbidity that comes with all of that? But there's also a general shift to actually moving towards a curative intent. And can we get rid of this clone before the patient ever really gets a malignant diagnosis? So there are a number of additions, again, to build on that Lendex backbone that was the first useful therapy, and then the addition of carfilzomib to RD. There are a number of other drugs, as you see them up there, elotuzumab, Nivo, Ixa, and then to build on the Kyprolis RD followed by transplant, and this is, again, probably the best example we have of let's cure smoldering myeloma. There are a number of other active agents, and these, again, targeting not only the tumor itself, but the microenvironment, the PD-1, IL-6, some of these, of course, we use in active myeloma as well, but some aren't even in our toolbox yet and are now finding their way into the precursor world. And even newer agents, certain things that have no name, they're still in letters and numbers, and somebody is finding that it's worthwhile evaluating these, and again, trying to alter the microenvironment. I think if we can make that marrow inhospitable and prevent the myeloma from hitting a threshold of active disease, we've done well by our patients. And so where do we go from here? I think, again, in another year or two, as the data starts to come in from all the ongoing studies, we'll have a much better role in how we evaluate and consider the response. So for me, there are 4 things for you to take home with and focus on between now and next year's meeting. One, which I think the IMW has already tasked itself with, is coming up with a unified risk stratification model. So do we use all 12 things we've identified? Can we replace some with others? Do the presence of a high risk, say by cytogenetics, trump another risk factor? Can we learn more about the pathophysiology of the disease itself and come up with which steps are required for transformation towards active disease, and maybe by targeting those pathways, inhibit the development of disease in a very logical way rather than sort of hit or miss. Again, targeting the microenvironment and the other players, not just the myeloma cells themselves. And using this depth of response. We used to call a complete response simply the disappearance of an M spike. We've come such a long way. The logs of depth of response continue to be redefined. So can we actually get to a place where the word cure can become a part of our vocabulary in myeloma? And with a minute to spare, that's all I have. Thank you.